and vitreolysis and sclerotomy revision. Now, sclerotomy revision is sometimes just using the YAG laser to trim the sclerotomy for advanced glaucoma when they have an implant. You can actually put a tonometer on this as well. But what I'm going to talk about now is probably some of the pearls that you're looking for. There are two manufacturers, really, of combination systems. There's Zeiss and there's ours. What's the difference between the two systems? There's a huge optical difference between the two systems. The actual system for the Zeiss has a single prism in which the laser and the treatment beam illumination comes through one prism. Now, if you're an ophthalmologist and a user of this laser system, combination system, you're most often using a contact lens. Contact lens may be spherical or they may be flat. But laser contact lens, if you just look into the laser system with illumination, you get direct illumination back, and what happens? You have a lot of white light coming back at you. To eliminate that, the classic split illumination system is employed with the Nidek, where you can swing the illumination to the side, where the actual illumination comes in, hits the mirror, and bounces out, and you don't see that reflection. With a Zeiss laser, you're having to tilt the lens or do other kinds of things to reduce the reflection. Now you say, okay, I can move my Zeiss laser to the side. The problem is, when you do that, either in the YAG mode or the 532 mode, you're introducing astigmatism. The actual laser beam comes from round to oblong shape, and so your power density is then affected, and your treatment parameters are affected. So what you want to do as a physician, it's all about, when it comes to YAG lasers or even photocoagulation, it's all about good imaging. It's all about good visualization of your target tissue. So if you can reduce the reflections, keep your laser beam round, so forth and so on. Let's just take a capsulotomy, for example, or iridotomy. A capsulotomy with the Zeiss laser, for example, is a combo system, is more difficult because when you reduce the reflection, sometimes you're not getting, you're actually clipping on the iris when you're getting to your target tissue. Some of the patients that I know have certain kinds of diseases, they don't like to be dilated very well. When you try to dilate them, they still don't want to be dilated past 3 or 4 millimeters. So this is a restriction to that prism system that we talked about versus the split prism, where you can swing it aside and then keep your aiming beam and your treatment beam straight ahead and able to treat both in the anterior segment and the posterior segment with plenty of illumination. When you have the prism system, you don't have the illumination going all the way to the back because it's tilted slightly. It's more set up for the YAG laser, and you don't get, it's very dim into the posterior segment. So you can see all the controls here on the Nidek are located right in the YAG portion, or right in front of the treating physician. Also, the control box for the 532 is located here. The actual switch is located on the combination adapter on top, where it's just a lever that goes from one type of wavelength to the other, and it actually turns on both systems when you do that. So it turns off the system that you've left and turns on the system that you're going to, so it recognizes that. So if we can just focus on the green laser for a second, it has a very small footprint, the smallest footprint on the marketplace, and it's very quiet, low power, intuitive, and very safe. If I go back to this slide here, we can see how easy it is. If you're left-handed or right-handed, you can move that control box to either side. It's actually located just below the tabletop, so there's no space required for the actual 532 laser, and of course the YAG is located here. So everything is very, very small and compact. And the doctors love that because they can do a lot of their treatments in one setting. This control box as well can be, and this laser can be taken from the, if you have a particular doctor who does some work in the, does vitrectomies, for example, and wants a endo laser, this can actually be detached very easily and taken to the OR. So you can, so the doctor, the key to this whole product is not only the functionality, but it can do a little of everything. It can do everything the doctor wants to do. If he wants to take it from office to office, he can do that. If he wants to take it to the OR, he can do that. But the most important thing, he saves space and he saves money. You can see the laser actually located here, and that's the complete system here. Very slick. So this is an animation of a capsulotomy. So actually it was sent to me by a doctor. He said this is what's really happening with a capsulotomy. We know that the YAG laser, that it doesn't actually cut the tissue. It makes like a sound wave or a shock wave that cuts the tissue. So this shock wave here will come back and actually cut the tissue here. So one of the differences in what the doctor likes about this is, and you should know this when you speak to your doctors, is that all YAG lasers are only calibrated at 1 millijoule. We talked about this recently in Brazil. And doctors don't know that. They think, well, I'm going to turn up the power and my calibration is going to stay the same. It's not true, because some capsulotomies require more power than others, depending on the fibrotic component. So if they need more power, let's say they normally do 1.2 millijoules and they need 1.6, 1.8, they have to set the offset. So push the laser back because, thank you, because what happens is that the plasma formation wants to come back anteriorly as we turn up the power. So that shock wave gets closer and closer to the tissue, and guess what? Some of the new IOLs that are being implanted now are very, very close to that capsule and sometimes almost touching them. So you want to do is to push back and then carefully come back at 25 micron steps until you start tickling that capsule and cutting the capsule without pitting or fogging the lens. Understand, pitting is for PMMA lens and fogging is for silicone lenses. And the doctors don't want that. That's why they start in the periphery. Another thing that you might want to introduce to your doctors when using the YAG laser is if there's astigmatism when he's doing capsulotomy surgery, he'll notice that he can't get his two aiming beams together. They won't come together completely. So what you do, and this is a very unique feature for the Nidek YAG, you can rotate the aiming beams by 90 degrees. No one else can rotate their aiming beams. You rotate it by 90 degrees and you reduce the astigmatism, you bring them together, and you reduce the amount of pitting or fogging that you would do with an IOL. Again, it's the only system that has rotating aiming beams and 25 micron step offsets, so that you can teach your doctors to be better surgeons, faster surgeons, without harming the patient's IOL in a very short period of time. And they like that. They like the idea that you're helping them do a better job by fully utilizing the product. The product is very unique in so many different ways. That's why doctors are going to if they're going to go with a combination system, they look at ours first. That's why our market share is so high, for that reason. Previously we had we didn't have enough illumination. Now we have plenty of illumination to do the job. So you can see what happens here when we're doing iridotomies here. We know that we use higher power, and we use higher power. And this is actually millijoules rather than millimeters. So 375 millijoules for blue and about 500 millijoules or 5 millijoules, if you will, 375 for brown. Because the brown iRide is 3 times thicker, you need more power. And the brown iRide is it leans more for swelling or edema. So you might have, starting off with 3 times thicker, it might be 6 times thicker, so it's almost like, in some cases, peeling an onion. You start going and you shoot and you get debris, you shoot again, and so forth. So some doctors, if there's edematous iris, it will take many shots and he'll get some pigmentation changes there, but he'll get through. All right, and I recommend not 3 shots a minute as listed here by the doctor. I recommend 1. Why? Because when you put